No. Good morning, everyone.
Aimachinoam lefsagie.
And welcome to the first Awareness Day for Pain During Sexual Relations. I have to say there's a peak of excitement among us. All the partners and I are very excited. We wish for us to have a successful and enjoyable day. We will begin with greetings. And the first to offer greetings is Professor David Schwicki. He is the head of the Department of Obstetrics and Gynecology at the Hadassah Medical Center. Good morning, everyone. This is very moving. It was very moving to see the preparations for this conference. I really want to express my appreciation to the entire steering committee for the preparation of this Awareness Day, and especially to two particularly esteemed women, Professor Ahinoam Lefsagi and Dr. Mijel Luria. Each of them a trailblazer. What you might call the first to identify problems that are very common in women's health, and also to advance them in an extraordinary way, in Israel and around the world. And I think this topic of addressing pain during sexual relations is a subject we all encounter every day. In our clinics. And especially in the unspoken world. That is to say, many people consider pain in relationships as part of the package. And they move on. And I think that just looking at the program for the conference, it was amazing to see the number of faces this issue has. So I want to take this opportunity to also thank the management of Hadassah, to Professor Yoram Weiss, Director General of Hadassah, for their support of this conference and the marketing department of Hadassah. And to everyone involved, I wish us all a pleasant day. And an informative one, and I hope the news that comes out of today will truly have a positive impact on health and on the quality of life for women and men. So enjoy. And thank you very much, Duty. And thank you from us for your support. Both yours, Dr. Yuval Lavi's, and mine. I'm happy to invite Dr. Yuval Lavi, Head of Obstetrics and Gynecology at Hadassah Mount Scopus. That's the medical center for both Mijel and me, to give his blessing. Good morning, thank you. Thank you for the invitation. As some of you may know, I am a urogynecologist and I thought I'd speak a few words about that. As a urogynecologist, I encounter the same women every week who have suffered from urinary leakage for years. They are hesitant to come and talk about it. It's a problem that affects their quality of life. It impacts them socially, professionally, and intimately, but they avoid sharing this issue, even with friends, their partners, and the medical system. And this avoidance is actually due to a combination of embarrassment, lack of knowledge, and sometimes the thought that the solution is simple and easy, and it's possible to return to full functioning. And why do I say that? Because it's also about some kind of silencing that leads to loneliness. And we essentially call it what's known as an invisible wound. So what is an invisible wound? It's a concept that's relevant to many medical situations. The environment essentially fails to recognize the suffering because the injury isn't necessarily visible. But at the same time, the person affected is hurt and feels embarrassed. They struggle to bring up the issue with those around them and with the medical system. So, the situation essentially causes double suffering. It causes both physical and emotional pain. And it's paralyzing because this burden of concealment is accompanied by shame. It's accompanied by repression. And it's accompanied by anxiety. Very difficult. So we're seeing this more and more today in communication with soldiers, with post-traumatic stress. We're seeing it in various medical situations. These include fibromyalgia, depression, and of course in women and men who suffer from relationship pain issues. In all these cases, the patients are essentially afraid or ashamed to complain. They are afraid or ashamed even when speaking to their partners or their spouses, and also to the medical system. Therefore, I think it's time to stop with phrases like, "It's all in your head," or "You need to learn." You need to learn to deal with it. So when we're talking about dyspareunia, which is essentially today's topic, the truth is one. Sexual relations, of course, are something that shouldn't be painful. And pain is always a signal of something not right. Just like with post-trauma, it's not just about the body. It seeps into the mind. So a transparent wound isn't any less real than an open wound. The medical system must address this issue, and it must convey a clear and unambiguous message. We, as professionals, are first and foremost committed to raising public awareness, and to enable more and more patients to bring this issue forward, and of course subsequently to offer them supportive assistance to help with diagnosis, and to provide multidisciplinary medical care, both medical and emotional, sexual and couples therapy, for anyone who suffers from dyspareunia. And that's essentially the goal of today, to uplift them. My colleagues S01 Levsagi and Mijel Luria. It's meant to essentially make the invisible visible, and to break down the walls of embarrassment. Following duty's blessings, I'm really very happy that two doctors from our department, established this day. And initiated a day that is so special. To the marketing department, to Professor Yoram Weiss, and of course to Sharon Pelegnesher as well. Thanks to her, thanks to the initiative, she also helped receiving international sponsorship, which is truly wonderful, from the International Company for Sexual Medicine and the company researching vulvar and vagina diseases. They are all working together to establish this day. So again, congratulations to everyone involved. To S01's right-hand assistant, who helped with all the technical matters. And I'm sure it will be a wonderful day. So good luck. Thank you very much. Well, thank you all. And let's dive into this exciting day. And that's it. It's a great honor and a pleasure to introduce Professor S01 Levsagi. In fact, she conceived of this idea, that there would be such a day every day. Even to the point of pain during sexual relations. Professor Levsagi is a specialist in vulvar and vaginal diseases. As mentioned, she's from obstetrics and gynecology at Hadassah Mount Scopus. She also works at the Claret Health Fund Center for Women's Health in Ramat Eshkol, Jerusalem. She also works at a clinic in Modi'in. And she'll talk to us. First, let's discuss why we chose to focus on this day, and about common problems we encounter. S01, what will you talk to us about? And your stage? So, thank you very much, and thank you to all the people who came to wish us well, to all those present and to all the lecturers. 2 lectures back to back. My first lecture is why at all? We established Awareness Day for pain during sex and the story behind it? Actually, about 4 months ago at the clinic, a 28-year-old female patient enters. She notes that she actually came for an examination because she has had pain during sexual intercourse since the beginning at the age of 22. She was examined during those 6 years by 4 female doctors. The first doctor told her she had a yeast infection. The second doctor examined her and told her that she had nothing. The doctor said that she likely had an emotional or mental problem. It's all in her head, and she was referred for psychological treatment. But she feels that's not the right approach. Therefore, she hasn't sought emotional support. The fourth doctor she's seen has also done so, and recommended she drink wine to help her relax and have pain-free sex. After examining this woman, Her diagnoses are that something is partially blocking her, and there's excessive tension in her pelvic floor muscles. I will discuss both of these issues further and on that same day. I was just wondering how it can be that in the year 2026 there are still doctors recommending women to drink alcohol. To deal with pain during sex, this is the way. The path to deciding to hold this awareness day was brief, because I believe that a large part of the problems we see stem from a lack of awareness. This lack of awareness exists both among individuals and within the medical system. So, I'll start with a little bit of statistics. The statistics aren't entirely clear. They depend on the population and the research question, but we estimate that at least 1 in 5 women, 20%, suffers from severe pain during penetration. In various studies, this prevalence ranged between 8 and 28%. We conducted a study in the delivery room at Hadassah Mount Scopus. It appeared 7 years ago. We asked approximately every woman who came to the delivery room if she was experiencing pain during sexual intercourse. 40% of the women told us they have pain during sex. This represents a percentage of all the women who came to give birth. First, they reported experiencing severe pain during sexual activity. The figure I always cite, 20%, is in the general population. Women after childbirth? There are quite a few studies. The prevalence of pain during sexual intercourse is between 30% and 60%. It depends on the timing. The closer a woman is to giving birth, the more common it becomes. This means there's a greater chance she will experience pain during sexual intercourse. And also menopause, from 18 to 40% of women suffer from pain during sexual intercourse. These studies are very difficult. It's very hard to know exactly how many women are suffering, but roughly these are the numbers we're talking about. And the problem is that many women who experience pain during sex aren't even aware that it's a problem. Even when they are aware that it's an issue, they aren't aware of the possible diagnoses or treatment options. We know this, and there's research on it as well. Despite the high prevalence, there's a delay in diagnosis. As I mentioned, because of the lack of awareness about this problem, medical evaluations are often inadequate. Doctors don't know enough about what to look for during an examination. The result is a delay of between 2 and 3 years, or even longer, in diagnosis. During this time, the woman experiences pain. She is not even aware that there is a problem, or she already understands that there is an issue, but she is still trying to navigate the system. This creates a negative physical cycle. It is, among other things, mediated by a muscle overcontraction response of the pelvic floor. I will elaborate on this further in a few slides. And of course, there are emotional implications that include feelings of shame and guilt. I think a huge portion of us as therapists know women who come in and say, "I felt defective. I felt broken." Part of our initial work is to explain to them that they are absolutely not broken. There's a lot of damage to self-esteem, frustration, depression, and anxiety. A lot. Components of damage in relationships and sexuality. Also in the partner's sexuality, with consequences related to the partner themselves. And all of these things cause effects that are long-term, what I call post-trauma effect. That is, a woman who started with a relatively defined physical problem, did not receive appropriate care, developed all of these consequences. Ultimately, even after we manage to overcome the physical problem of that woman, she often remains with a large part of these emotional components. It takes her many years to overcome them as a sort of prolonged post-trauma effect. Therefore, it's clear that the sooner we diagnose the situation, the better it will be. The problem is that there are many professionals who aren't aware of the high prevalence. They also aren't aware of the severe consequences. I don't want to say harsh things, but I've encountered many women, and I've seen quite a few responses that are dismissive even towards us. Those working in the field sometimes show disrespect towards people as well. There's a tendency to exaggerate how we describe this situation. So we're here today to change that. We're here to say that sex shouldn't hurt. We're here to say that pain during sex is a common problem. We shouldn't ignore it. This problem isn't just a women's issue. It affects men as partners and as individuals who may be suffering themselves. And we have an entire session dedicated to pain during sex in men. The pain can stem from a wide range of physical, emotional, and relationship issues. That is to say, the woman may also have physical problems. She may also have emotional problems. And everything that results from that. We are here to say that this is not a reason to be ashamed. And this is not a reason to hide. Everyone deserves an accurate diagnosis and appropriate treatment. Today, this is for people and men who don't know that this is an abnormal condition. I often hear women telling me, "I didn't even know this was an abnormal condition. None of my friends experience this. The doctor told me everyone has pain after childbirth." And then I realized that I wasn't supposed to experience pain ever. I went to a pelvic floor physical therapist because of urinary leakage. And then she told me it's not right for me to have pain during sex. Or patients tell me, I've been suffering in silence for years, completely unaware that there are solutions. This day is also for all the women who heard all the wrong statements. There's a selection of statements here. Yesterday, I read in response to some article that someone wrote to a woman experiencing pain during sex to take Tylenol. Not Tylenol doesn't help with pain during sex, and statements like it's all in your head. You'll get over it after childbirth. Change something. Drink alcohol. Illegitimate statements are not solutions, and they shouldn't even be said in a humorous tone. And this day is also for everyone who has been diagnosed or has been diagnosed and is still struggling. We know that along the way you've become discouraged, you've been disappointed, so I want to remind you that you are not alone. I must note that we are also improving over the years. We are becoming better doctors. We understand more things. So it's worthwhile for anyone who has become discouraged to return for an evaluation or reach out to another professional. I am always a very optimistic person. I always believe there are solutions we haven't thought of. This day is also for us, the professionals. We want to raise awareness first and foremost. We want to increase knowledge. We want to be exposed to other areas of treatment. We want to learn about solutions we weren't previously aware of or had considered. I think a sense of belonging is also very important to us. We are a community of professionals. We need to get to know one another. This will allow us to refer people to each other. This will also allow us to consult with one another. And because this journey of treating people with pain, women with pain, is a long and difficult one, it's important to me and to us caregivers to feel a sense of belonging. And the fact that I belong to a whole community of caregivers that I can rely on. I'd like to add my thanks to the steering committee. I truly don't have the words to express my appreciation for all the people who contributed to this story with such enthusiasm. Here's the list of those who served on the advisory board and agreed to reach out and come speak. And to everyone who was involved with this on behalf of the Hadassah Medical Center. To Professor Yoram Weiss, who approved and provided financial support for this day. And to the marketing department of Hadassah Hospital, thank you very much. We wouldn't have been able to do it without you. This day of ours is a long one. And interesting. And I hope we all leave here with at least one new insight. And my message is that Awareness Day shouldn't actually remain just one day. It should become a continuous awareness. I ask you to share with your colleagues, patients, and clients what you hear here today. There will be a recording of the webinar. People will be able to be directed to the webinar. It will be free and available to everyone. Please share it on social media. Everyone is invited to join us for the public webinar on Thursday, May 14, 26. We will also send a link to that. This is to mark the occasion. I hope raising awareness about pain during sexual relations will open the door for this topic to be more represented. In art, in literature, in film, people often talk about how young women feel when they see someone like themselves in a movie or book. They receive some kind of validation for their problem, so I really hope. I'm speaking to everyone involved in different areas of art and media. Please think about this. And I'll move directly to discussing the physical factors. The pain during sexual relations. There are many factors responsible for pain during sexual relations. They are also responsible for the location of the pain, and also for different timing of the pain, so the pain can be pain during penetration. What we also call superficial pain. The pain can be deep. It can be felt in the internal organs or in the pelvis. Pain can be a result of friction. And there's a situation where there is pain after sex. And of course, unfortunately, a woman may experience all of these situations or some of them. So, deep dyspareunia or deep pain during sexual relations is a type of problem. It involves the pelvic organs. It can involve the uterus, the pelvis, the bladder, and the rectum. Examples? Another condition that causes pain originating in the uterus is endometriosis. Fibroids located in a problematic area or scars, including a cesarean section scar. The pain can be in the pelvis as a result of adhesions from surgeries. They can also be caused by pelvic inflammation or endometriosis. There will be a separate lecture on endometriosis later. The pain can originate from the bladder. This happens, for example, in the case of painful bladder syndrome. The pain can also stem from the rectum. This occurs in cases of inflammatory bowel disease, such as Crohn's disease or ulcerative colitis. Many times women tell me their pain is a deep pain. And then, during an examination, I identify that the pain is coming from a source in the pelvic floor muscles. They are located about 3 or 4 centimeters. They open the vagina, but even this pain is experienced and described as a deep pain. Pain after sexual activity isn't specific. It often stems from pressure on the pelvic floor muscles during intercourse, perhaps an allergy to semen, or simply a reaction to the fluid itself. And some women experience recurring urinary tract infections or yeast infections following sexual activity. This too can contribute to chronic pain. Dyspareunia during penetration is actually my area of expertise. It's a condition that arises from the involvement of tissues located in the vulva. Inside the package, these tissues could be vestibular. Vestibular tissue is located right at the opening of the vagina. Any inflammation, any condition of estrogen deficiency, can cause inflammation of the vestibular tissue. It can also cause pain during intercourse. This can be due to the involvement of skin around the opening. Any inflammation, chronic fungal infections, skin inflammations, skin conditions such as lichen sclerosis. I will dedicate a separate and comprehensive lecture to it. A diagnosis that, in my opinion, is not well enough known. What is mistakenly called the Hyman's membrane if it is relatively narrow. This causes significant pain. There can be other situations of structural narrowing. For example, a congenital condition or a skin disease such as lichen sclerosis that scarred the vaginal opening, or scarring resulting from trauma during childbirth or surgery. Surgeries of the pelvic floor and pain can also be due to excessive muscle contraction. These are superficial and deep muscles. This happens during the day. This list will become separate lectures from some unclear listing. So I hope things will be much clearer. It is at the end. This one. The differential diagnosis is very broad and is actually also related to the timing of the appearance. So in fact, throughout a woman's life, any chronic inflammation can manifest as pain during sexual intercourse. I mentioned recurrent vaginal yeast infections. About 10% of women in the population experience them. They have a condition called recurrent vulvovaginal candidiasis. This can cause pain during sexual intercourse, but any other inflammation or skin conditions can also. Tightened pelvic floor muscles is also a finding. It's an almost universal finding, and it can occur at any stage of a woman's life, and is secondary to any other problem. It will cause reactive muscle spasms. And then the pelvic floor muscles will take over the role of pain on their own. And additionally, it affects other issues. I'll expand on pelvic floor muscle spasms shortly. But when I look at different situations throughout a woman's life, I find that there are diagnoses that are related to timing. So women who come complaining of initial pains, meaning pains that a woman experiences for the first time she begins having sexual relations, and that's still within the range of before childbirth. I'll find the diagnosis of partial hymen obstruction. I have a session on it at 10:50. I have a session about it. You are invited to join. There could be provoked vestibulodynia, a state of. A secondary condition means a condition where the woman describes having months or years without pain. And one bright day, or through some gradual process, she began to experience pain with penetration. This happens as a result of provoked vestibulodynia, or as a result of some kind of scar tissue or acquired narrowing. This is the thing we need to identify in the woman's history. For example, if it started after childbirth, then we understand that it could be related to immediate scar tissue. After vaginal childbirth, a very common issue is a lack of estrogen as a result of breastfeeding. A lack of estrogen can cause painful intercourse. This condition is relatively easy to treat. And scar tissue resulting from stitches. Women who have gone through menopause also experience these estrogen deficiency issues again. A very interesting phenomenon of secondary stenosis occurs as a result of the changes from declining estrogen levels. There are also changes in connective tissue. And I really see a narrowing of the vaginal opening or various scars that a woman has had as a result of childbirth. And they've never bothered her before. They start to bother her around the time of menopause. So, if I'm summarizing, there are situations where they can be present throughout a woman's life, like infections or excessive tightening of the pelvic floor muscles. But there are diagnoses that I will look for specifically in different situations. And we dedicated a lecture to each of these things. So I've highlighted in blue all the situations we dedicated time to. Separate lectures if they involve partial blockage of hymen, pain after childbirth, vaginal issues, or menopause. That leaves me to talk now about pelvic floor muscle spasms, vestibulodynia, or pain from touch. Pelvic floor muscles are key players in this topic of painful intercourse. The external and internal muscles can be seen in this diagram. I'll put a pointer on it now. Okay, so you can see the superficial muscles located here. This muscle is called bulbospongiosus. It's located right beneath the labia minor and the muscles. The deeper ones are here in this section on the upper left, where I've placed 2 red arrows. The lower red arrow indicates the superficial muscles, and the upper red arrow indicates the deeper muscles. And these muscles can both be involved, or just one of them can be involved, or even just on one side and not the other when we are trying to understand why there is a state of muscle overactivity. So it's important to remember that the pelvic floor muscles have 3 main functions. First, these muscles support the pelvic organs. Therefore, any postural problem will manifest as muscle overactivity and pain. Sorry, that was their role as muscles participating in posture. These muscles support the pelvic organs that sit on them. And these muscles are actually the sphincter muscles. There's a sphincter of the anus, and there's a sphincter of the urethra. They are actually located at the vaginal opening, and they also contract the opening of the vagina itself. The list of problems that cause excessive contraction of the pelvic floor muscles are a long list, as I mentioned. It can be reactive to any pain and excessive contraction, and a nearly universal finding in women who experience pain during sexual intercourse. This is also true for pain from shallow penetration to deep penetration. Women develop excessive contraction. Therefore, they are often treated. They tell me that the pain started, and over the years the pain became increasingly severe, until it became impossible to have sexual relations. So, I suspect from the outset that the pelvic floor muscles are involved. There can be emotional components as well. People tense muscles in response to emotional factors, and then it becomes essentially both the chicken and the egg. If it's a negative cycle, we know that these emotional factors can be related to problems in relationships. In relationships to some previous trauma involving intimacy, or to situations even involving a lack of desire. And these emotional factors can be completely unrelated to intimacy, like post-trauma, anxiety, and other health issues. Orthopedic problems. I mentioned that the muscles actually play a role in posture. So any postural problem can cause excessive muscle tension and pain. Situations of injury, such as during childbirth with muscle tears or damage to the muscles during pregnancy. Pregnancy where the heavy uterus sits on the muscles. This causes them to tense up. We see many women coming in mid-pregnancy with pain during intercourse. These pains began during the pregnancy. It's actually due to the pressure on the pelvic floor. Any issue, infections or problems in the urinary system, share the pelvic floor muscles with the vagina. This can cause excessive contractions. Strenuous physical activity, we've all seen it, everyone in the field, patients doing TRX or Pilates. They are doing so with pain during sexual activity. I always tell my Pilates students, you're constantly being told to contract but never told to release. That's a very, very important component. Releasing the pelvic floor muscles and other issues that cause excessive contraction, like fibromyalgia, is also key. Or situations involving stress. I often tell women, you have too much muscle tension. Sounds like a good thing to them. Excessive contraction isn't good, because we know that weakness causes urinary leakage. So, it's important to remember that anything taken to an extreme isn't good. It's 2 sides of the same coin. Now I want to move on and talk about vestibulodynia. Provoked vestibule contact. Contact, also called vestibulitis or vulvodynia. In fact, the definition of vulvodynia states that it involves pain in the vulva that lasts for more than 3 months, without finding a cause to explain the complaints. So these pains can be pain without contact. They can be pain with contact. They can be throughout the vulva or only in parts of it. And they can be vestibular, which I marked here. Now, since we are only interested in pains today, with contact during sexual intercourse, so I will remove the pains without contact. and I will disregard the situations that occur in the entire vulva. And I am essentially remaining with the group of pains with contact in the vestibule. This is something that someone else named. But international organizations gave it a different name. And it's called provoked vestibulodynia, or contact vestibulodynia. So, essentially, pain with contact in the vestibule is a specific case of vulvodynia. The diagnosis is made based on appropriate complaints of pain during penetration, elicitation of pain with contact of the speculum in the vestibule, and the statement "I wrote this at the beginning of the slide" means there is no factor explaining the complaints. And here I want to put a question mark over this sentence, because I'm saying that I can't find a factor explaining the complaints. I can essentially say two things. Was the examination sufficient? Many times no. That is to say, not all possible factors were taken into consideration. The second possibility is that this is nosoplastic pain. We have an entire session on nosoplastic pain. This essentially means there is a disruption in the processing of pain within the central nervous system, without any damage to the tissue or the nervous system. In other words, it's not just a catch-all term for everything we don't understand. Rather, it suggests that perhaps we haven't examined things thoroughly enough, or we are actually talking about pain itself. And I want to mention here vestibular sensitivity from touch. That's essentially a definition that refers to a symptom, and it's not the name of a disease. Everyone who knows me knows I always say that at this point. Coughing isn't the name of a disease either. It's a symptom of many different illnesses. So, pain in the vestibule actually indicates a collection of different problems. They have a similar presentation. In practice, in the clinic today, there are two different approaches to treating vestibulitis pain. Regarding what we call vestibular sensitivity from touch, or vestibulitis, there are many doctors and therapists in the field who say it's pain from unclear touch. Sorry, pain from touch that's of unclear origin. And then management is often done through a process of trial and error. You try a treatment, see if it works, and so on. My approach is different. I tend to divide into subgroups based on the location of the pain. There's very little on that. Studies exist, but generally there aren't many good studies on the topic of vulvodynia. Most studies don't even differentiate between pain with contact and pain without contact, which, in my personal opinion, are two different things. And my approach essentially means that I first categorize based on the location of the pain. Women who experience pain with contact throughout the vestibule, meaning wherever I touch it hurts them, or women who experience pain only in the lower part. Women who experience pain and pleasure often find that this is frequently due to hormonal changes, primarily from using birth control pills, or from a condition involving an excess of nerve cells. You can see here on the left a work published almost 30 years ago. The study shows a difference between biopsies from two women. The woman in the image above is a woman without pain, and the woman in the image below is a woman with pain during penetration. You can see that there are many more white spots here. These white spots represent nerves that are located in the vestibule, so you can understand why the woman is experiencing pain, and she has a lot more nerve cells. In contrast, pains that are only in the lower vestibule stem from the same distribution. The doctor who actually came up with this distribution was an American physician. His name is Dr. Andrew Goldstein, and I've adopted his approach. And the lower sensitivity stems from excessive contraction of the pelvic floor muscles, or from a partial blocker, which we'll discuss later. So to summarize, I want to recap and say that there are many physical factors contributing to pain during sexual intercourse. In order to treat it, we first need to diagnose. And my message to practitioners is, don't ask how to treat it, but first ask what the diagnosis is. That will guide you. It's important to remember that often women experiencing pain with penetration or deep pain have a physical cause. And we need to avoid automatically thinking of emotional pathology as the source of the pain, and not send women for psychological treatment. No exclusively if you are not working in this field. I am asking you to be proactive. You need to ask about pain during sexual intercourse. I am referring this to a family doctor, gynecologists who don't deal with this area, and also regarding visits to the labor and delivery room. And if the woman mentions that she has pain, refer her onward to receive. Also, you need excellent familiarity with vulvar and vaginal diseases, so as not to say there is pain without a cause. And you should remember that pain with vestibulary stimulation is a symptom of various problems. Vulvodynia or vestibulodynia from this stimulation is not a disease name, but a symptom. I want to remind all of us that dyspareunia is clearly needed. To attribute to the relevant differential diagnosis, a woman before childbirth suffers from various problems. A woman after childbirth, or a woman in menopause, And it's very, very important to remember that physical factors are only part of the overall picture. As I said, the patients already come to us with many emotional components, physical components, and we won't be able to help them if we don't address all of these factors. Thank you very much. And I'd like to invite the next speaker, Dr. Michael Luria. She will speak about emotional aspects of pain in sexual relationships. Specifically, vaginal pain and anxiety about penetration. Dr. Luria. She is a gynecologist and sex therapist. The president of ISAT, the Israeli Association for Sex Therapy, is the director of the Sexual Health Center at Hadassah Mount Scopus. She is also a co-director of the Israeli Center for Sex and Couples Therapy, Rudam Center in Jerusalem. And I would like to add a personal thank you to Michael here. She essentially spent the day with me, and she was my partner throughout the process, and we too were. I think we feel incredibly lucky about the relationship that grew out of this shared work. Thank you, Michael. Thank you so much. So, the official name is pain in relationships. Sex causes emotional distress and hesitation. But we will have an entire session to detail that. I will touch on it a bit though, but I mainly want to focus on the topic of the vagina, because many people get confused between vulvodynia, various pain disorders, and vaginal moss, which is actually something completely different. So, if a woman comes in, it might be the sister of the woman you presented, or a young woman coming up to her wedding. Is she secular or not? Is she meticulous or not? Because we see this in all sectors, across all socioeconomic backgrounds. These are issues women face throughout their lives. And within the population, she comes to us because of difficulty inserting into the vagina, and she is afraid of pain, and it actually hurts her. And then she has the million-dollar question, is this psychological? So we know that in relationships, the body and mind are connected to the pain. And even in Genesis Moss, there are biological components. There's what's said, the pelvic floor muscles, the nervous system, hormones. There are so many factors and also psychological components, both distant and close. Distant things are events that happened to us many years ago in childhood. Close ones are indeed the present, fear, memories, expectations, and so on. There are also many factors. I'll elaborate on those soon. This will happen in the next session. There are social components as well, and we call it biopsychosocial. All of these things go into the mix. And ultimately, when we have the complete picture, it's very difficult for us to say whether it's this or that. It's really the interaction, the combination of all these things together. We do know that there are areas in the brain where emotions are actually encoded. They also meet there along with pain. They also meet there for ammonia. And there's a direct connection between these things. We have studies that show how emotions and thoughts influence pain. And also the reverse, how memories affect pain. How does the expectation of pain influence it? And does a physical or romantic catastrophe play a role? Does thinking about the same thing repeatedly impact it? Here it comes. Here it will hurt. What kind of catastrophe is it? Things will never get better for me. Catastrophic thoughts. All of this affects the pain. Do we know empathy? Have you ever seen someone suffering and felt pain yourself? That is to say, the pains are influenced, of course, by emotional things. But I want to talk about vaginas, which are actually a difficulty. Allowing entry into the vagina by a penis, finger, or anything else. Even though the woman says she wants something to enter her vagina. And this is a situation where there's an involuntary contraction of the pelvic floor. These are voluntary muscles. We know how to contract so that urine doesn't leak. And we know how to relax when using the restroom, but sometimes they contract involuntarily. And there's also phobic avoidance here. That means a fear of enclosed spaces, of heights. So the natural tendency will be to avoid this encounter. And often, there's also hesitation in trying to have relations that involve penetration. Even seeking treatment from therapists. Because of the avoidance, you can't be angry at the avoidance. It essentially expresses a deep fear. A deep fear facing the specific situation. And it can be painful. But it could be that there won't be any pain, but a very great fear of pain. So what is a phobia? A phobia is an intense and persistent fear. It has a reaction, a specific physical response. This image that's covering what's written underneath should be included in the animation. But we know how to say, for example, we recognize it in a phobia of blood tests. People faint when they have a blood test. Or with people who have claustrophobia and feel short of breath in an enclosed space. It's usually a specific symptom related to a specific event. A physical reaction and a desire to avoid, as I already mentioned. What else do we know about the vagina? It's a fear of pain, a fear of bleeding. We meet these women and ask them what comes to mind when you think about the possibility of something entering the vagina. Some will say, I imagine that maybe I'll be an unusual person who will get hurt, who will feel a lot of pain. Most of them are women who are also very afraid of a medical exam or a gynecological exam. Specifically, too, fears about childbirth. Exclusive to them, it's actually the appearance of disgust. Often, they feel disgusted with themselves because of discharge during self-examination. This happens from a foreign fluid semen, and not just sometimes but disgust. Cooked meat patties, textures, disgust. It's a mechanism designed to protect us from contamination. And there's also moral disgust. And sometimes women and men feel disgust at something they grew up learning might not be right. Women with a history of moral injury will generally experience more anxiety. These anxieties relate to various topics. Anxiety is also a part of their personality. Women who describe themselves as generally anxious, and who often react with excessive anxiety to specific situations. Not necessarily, but it frequently comes with some kind of family background. Negative upbringing regarding gender and sexuality. Girls are raised to be good girls in society. He's someone who doesn't express anger very often. Mom who is also anxious but also intrusive. And sometimes mom is the one who schedules the appointment. Again, everything I'm saying isn't always. Just in certain situations. But these are things if we see a mother scheduling an appointment and a mother arrives with a 26-year-old daughter. Is there a chance that intergenerational anxiety is also a factor here? We're seeing it in Eastern cultures more than in Western cultures in recent years. A large number of the articles come from Eastern countries. The authors suppress female sexuality. In less liberal, more conservative societies, with strict moral standards and guilt. And we also encounter this in groups that have a lack of knowledge about sexuality. But essentially, that's how it's written in books and literature. I think that's true for all populations. Can we improve the issue of sexual knowledge, don't you think? People aren't learning about sexuality in an organized way, not at home and not in schools. And ultimately, most people learn about sexuality from sources that aren't always credible. It's something to consider when a couple comes in with difficulty with penetration. And all the focus goes to the woman. The diagnosis is often directed at the woman, suggesting she might have a vaginal imperforation, and she's the one seen as having the problem. It's important, of course, to look at the couple's system many times. Often, a key couple completes the problem. That is to say, because there have been several attempts to enter the vagina. So, a problem with erection or rapid ejaculation develops as a result. And it's also very, very logical that this would happen. But sometimes there's also a problem that was already present. Therefore, you also need to look at the partner. Because in some cases, it's the partner who has issues already. Essentially, the emphasis here is that it's very, very important to involve your partner in the therapeutic process. And that's true for every person and woman in a relationship. It's always important for your partner to participate in the process. Even though in the division of assets each person received what they received. But ultimately, dealing with the difficulty is a challenge that happens again when you're in a relationship. The challenge is for both partners. So what do you do? It's really, really important to take a comprehensive look at the history, psychosexual and medical. And to check everything as well. Everything the person has accumulated along the way. It starts from the moment they arrived on Earth. Their entire family history. Are there elements of fear, anxiety, or disgust? Is there a history of trauma? We'll talk about that a bit later as well. Is there an issue with emotional recognition, which is essentially difficulty identifying feelings or expressing them? And we know that people dealing with alexithymia have a high percentage of problems with sexual function in general. And with vaginismus, pain as well. A special consideration needs to be given to the avoidance component. And explain to women with vaginismus that this is one of the main obstacles. And that you need to constantly be in discussion with this avoidance and fight against it. Rule out issues with sensory regulation. These are also common in pain problems in general. As it is said, the partner and the relationship need to be part of the picture. And a gynecological exam is very, very important. Because many times because of the anxiety about the exam, the woman avoids it. And it's really important to emphasize that sometimes there are both anxiety and the need for the exam. It's not uncommon at all. It's even quite frequent that during an exam, it turns out there's a rigid hymenal ring. Or thick or wide, and also a phobia. And then the woman and her partner can be in therapy through long psychotherapy sessions. And then, after 2 years, to discover there's an anatomical factor. It's very unfortunate. Even though it's difficult and frightening, it might be very advisable to get checked as soon as possible. A checkup could definitely be part of a healing process. Another empowering experience, and we'll discuss it further. Women as opposed to men. Men have a visible sexual organ. They are friends. Our sexual organ is hidden from view. And to look and get to know each other is a project. You need to decide to take a look. Look closely. What we do during the examination is to get to know the woman, the man. Recognize their genitals. Very nice to meet you. This. Because if it's not part of the body's experience, then it's very difficult to embark on a healing journey, because I don't know how I managed the times. Seems like it's about to be over. So we'll expand on that later regarding how to do a test that is sensitive and empowering. And healing, maybe even a healing center, but mostly a healing center. It's important to address the gynecological exam in all the stages leading up to the exam itself. And to explain it, the steps are within the woman's control. She has control over what happens in her body. It's important to follow along as if watching a soccer game. Every movement, now I'm turning on the light, now I'm putting on gloves. A woman should be aware of everything happening around her. And she should have it control and be able to stop us if she's worried or if something hurts her. And how important it is to explain everything that happened afterward. Everything we saw. We will elaborate on that in one of the upcoming sessions. As the woman being examined will have information. She will have predictive ability. She will have control of the situation. Penetration or merging issues. Essentially, you can refer to the DSM book of psychiatric disorders. It has a chapter dedicated to that. One can argue whether it is justified or not, but there are several chapters on problems with sexual function. This chapter discusses what is called penetration disorders. It's a penetrating term. It's a difficult word, and most of us don't like it. Actually, it puts pain and the fear of pain in the same bag. It puts dyspraxia and hesitancy in the same category and asks of us, of the professionals, to look at 5 criteria. Is there a problem with entry into the vagina? Is there pain? Is there fear? Are there problems with the pelvic floor muscles? And is there any other medical issue? And that's how we essentially address these things together. But we also look at each thing separately. And we also take into account that sometimes there's a phobia, anxiety, or avoidance, as I mentioned. And we need to look at all of these things and explain them as well to the people we're facing, like for example today. These 11 hours are simply a psycho trip. It's about giving them all the information because knowledge is power. It's not just a saying. It's very true. When starting a process, especially a complex one, you need to check that there's a willingness to embark on the journey. Because sometimes it involves a lengthy process of several months. And you need to maintain the desire to move forward constantly. To board this ship sailing to Australia. And it's not. Sometimes it takes several good months. We caregivers need to hold on to hope and self-confidence. Sometimes women come and say there's no chance. I can't imagine anything going into my vagina ever. And we both know babies come out from there. And also, objects and instruments go into the vagina and we, along with the woman, are working on self-ability for very high exposure. It's very important for phobia treatments in general. If you walk down a dark alley and do that, it's a high fear. But if you do it every 5 minutes, then you gradually become less and less anxious. Sometimes we also use anti-anxiety medication as treatment. If anxiety is very present, you need to consider that partners sometimes avoid doing things which can perpetuate the problem. It can even worsen the difficulty. And sometimes it can also lead to dependence with partners telling you how to manage. Or saying directly or indirectly how you'll manage without them. And sometimes, the partner is dealing with anxieties just as much. And that's essentially, it's a challenge for both of you together. And the final word, or perhaps the first, to focus on pleasure. Because ultimately, entry is considered the main course. And everything else, sometimes the sexual contact of all kinds. Additional courses, less important. And we know that ultimately the goal of sexual contact, whether with oneself or with another, is that it be pleasant and good and connecting and enjoyable. This is a very important part of both treatment and life, of course. So thank you very much to all of you for being here. Thank you very much. Metronome. Thank you very much. The speaker. Our next speaker is Dr. Ohad Shoshani. He is a specialist in urological surgery. Rabin Medical Center is hosting the day for the Anthropology Department of the Israeli Urological Association. And Ohad will be speaking on the very important topic of pain during sexual intercourse in men. A topic that I think most of us, at least I as a gynecologist, know much less about. So thank you very much. Okay, so thank you very much. And also for the invitation, and I can talk about this important topic. And it really was an introductory lecture about male pattern baldness and its consequences. So first of all, the definition. It's problematic because when we talk about a receding hairline, hair loss in women then, series also in the various guides actually, and also in standards such as ICD-11, and also in the different professional organizations. When it comes to men, it's difficult to talk about dyspareunia in men. These are men who sometimes when talking about anu dyspareunia, and then it's possible to talk about dyspareunia, we are missing a definition of male dyspareunia. But therefore, no one, neither experts nor standards bodies nor professionals, has provided any official definition. That's right. It refers to most of the symptoms and problems in urological associations, like pain during ejaculation, chronic pelvic pain. But there isn't a definition that unifies these things into one definition and time frame together. Gender, and therefore, since there isn't such a definition or reference either, generally, it's a field that has been researched very sparsely in men. They also usually ask women more often. They ask them about pain and discomfort. And men are asked more about function, like erections or rapid ejaculation. So yes, there are articles that discuss the prevalence of the problem. For example, a large survey in 2005. Over 13,000 men from 29 countries. Between 3 and 12% of men reported pain during intercourse. It is coming. Rates for women, but I still think it's a significant rate. And a problematic one. 2012, almost 5,000 men, were about 2%, reported a chronic issue. That is, pain lasting at least 3 months. So, how can we classify male sexual pain? Can we categorize it using different categories, or pain is felt whether it's in the penis or testicles? It depends on the possible cause. Pain has a cause. Infectious or neurological, depending on the trigger. When does the pain appear? During sexual activity. During an erection. We decided to categorize it by the duration of the pain. How long does the pain last? There's a significant difference between acute, new pains and chronic pain. So there are differences in the various factors, and we thought that was the right approach. Order. Regarding the topic, and therefore the lectures will also be divided accordingly. We'll be discussing pain and its impact on overall function. So, if I have something on hand, it causes me some anxiety. Yes. Having something on hand means there's more focus, as Michael mentioned. Michael emphasized the location and the area, and the anxiety and pain persist. There's also time to implement changes in the nervous system and to become more sensitive. More pain, more anxiety. Less of a reaction. If my hand hurts, I'll move it less. If sex hurts, I'll have less sex. And there's a sort of negative feedback loop here. With myself. And there will be others who touch it with specific pains in the penis. Or the testicles. But it's important to remember that pain during sexual intercourse can be caused by pelvic pain in men as well. There is also pain herein by general pains, or others that are not specifically related to the organs or genitalia, but they do affect function. Pain can be related to a defect. Pain can be related to factors, and of course, psychological factors, and here a psychological issue is emerging. So, if we talk about the effects of pain on sexual health, for example, men aged 50 and older. Men who reported being sexually active, who suffered from moderate to severe pain. They reported a decrease in sexual function compared to men without pain. Severe. Also in the frequency of sexual intercourse, but also a decrease in masturbation and disturbances. Also a higher concern regarding their sexual health. Pain. From musculoskeletal sources, meaning generally, back pain or joint pain. 5%. 36% reported that they stop having sexual intercourse altogether. Men with chronic pain report more pain related to itching in the genital area. Also a decrease in desire. And difficulties with sexual arousal and orgasm. The severity of the pain was also found to correlate with the severity of the injury in sexual function, but there are also positive aspects. Yet, they are still able to maintain a satisfying sexual function, and that is a key point. It's important when a man is experiencing this. The severity of the damage diminishes, meaning there is significance to the mental and emotional impact of the pain on sexual health. How is the support? Then it's easier to overcome it. Many are not related to sexual relations, like fibromyalgia in men. See regarding sexual function. And also men with inguinal hernias. They also report pain during sexual activity even before the repair. And some of them even after the repair is done. A group and they still experience pain. As we mentioned, there are also issues with the pelvic floor. Dr. Ludiansky will discuss this in relation to pregnancy in men. Chronic pelvic pain. But I can say that the number of men I've seen coming in with pain is significant. And they've received diagnoses like chronic and been treated with antibiotics. It's countless. And when you are already doing a rectal exam, their pelvic floor is practically screaming. And there's a quality to it. It's much higher than the awareness of it. It's also important to raise awareness today that men have pelvic floors too. Pelvic floor disorders cause urinary and other issues in men as well, and vice versa. They can also negatively affect sexual function and cause pain during sexual activity or other activities. Otherwise, and in various jobs, there is also a very high prevalence of these disorders. Sexual function in men with chronic pain. You see that in this work, for example, a percentage reported disturbances in sexual function, or in terms of erectile dysfunction, or in terms of, there's also a concept like that, called hysparunia, a play of words in English around dysparunia, meaning his pain. The pain is caused to a man during sexual intercourse. It's caused by a factor of a partner not being. She underwent surgery in the pelvic region. There's some sort of encompassing support network that causes the pain. Of course, it could also be the reverse. A woman can experience pain or discomfort due to a factor with the man. For example, significant scoliosis. So, someone will speak with you further. A lecture will be given. It will discuss the acute factors, and you can see there's a long list. And Dr. Ludiansky will speak about the different factors. And here too, there's a long list of chronic factors that can cause problems and deficiencies. I will talk about discomfort during sexual relations. Yes. On a few slides about the topic of assessment and treatment. First, regarding the assessment, we need to overcome barriers. We need to overcome barriers in everything. Both for the patient and sometimes for the provider, we need to overcome time constraints. That is, there's a problem, there's an illness, and there's limited time with the doctor. We need to discuss this. About a lot of things. About the treatment. About the medications. And in the end, there isn't time to talk about even that. The impact on sexuality, and we need to overcome the barrier of despair. Yes, the more sex, the more discouraged we become. And we say, I don't need this anymore. We need this. Let's focus on other things. There's also an element of despair, so sometimes we avoid clarification. Just a medical history and a physical exam. Who handles that then? It's interesting work from Ichalov. He's more than half of the members of the Pain Medicine Association. Please complete the questionnaires. 80% in the high prevalence of sexual dysfunction disorders in patients with chronic pain. But only about 15 raise the issue of their patient's sexual functioning proactively. And about 90% report it. They have little to no training in sexual health and therefore do not. Ultimately, it's often a collaboration between different disciplines. Typically, the urologist will take the lead. but not always. It's a real challenge. There's cooperation between the urologist and the sexual therapist, as well as a physician, between the physical therapist and, of course, other disciplines depending on the issue. So what do we need to do? Well, of course, identify and address the root of the problem. Sometimes it's possible, sometimes it isn't. It gives us additional tools to deal with the problem. Even if we aren't able to resolve the problem, it does. Our goal is to reduce the pain and to treat double pain that is specific to pain, anxiety, and the emotional and mental effects on the experience of pain, which always happens, and to renew and support intimacy and sexual touch as much as possible within the framework. So the different treatments, of course, besides treatments tailored to the problem, we also talk about treatment for pain itself, about psychological treatment, about couples therapy. And often there are erectile dysfunction issues when there's difficulty having sexual relations due to pain. This also concerns erectile function, so we also need to address these disturbances, the erection. So I'll just finish up. And what to do then? Pain with red flags. Sharp, intense pain in the testicle, swelling in one testicle and the penis during sexual activity. This activity is sometimes accompanied by bleeding or blood in the urine. If there are neurological symptoms, such as a severe headache or sudden weakness. If there is intense pain but no warning signs, seek a medical examination. A urologist should be consulted first. And if there is chronic pain, and if the pain is acute, seek an examination with a urologist specializing in andrology. They are more focused on the lower abdomen. These are the types of pains experienced during sexual activity. Italy, and of course it's very important to pay attention to cooperation. This cooperation covers all topics related to pain. So get straight to the point. And I wish you a successful day. Enjoy. I see there are no questions. In bed. On behalf of the audience, there was one question. I will answer it aloud as well. Someone wrote, nerve cells don't only transmit the sensation of pain, so why is that? An explanation for pain in relationships? Doesn't a multitude of nerve endings also have the potential for a multitude of pleasures? So I just want to remind you that there are different types of conduction. There are feelings of pain and there are feelings of itching. There are feelings of burning, a searing sensation. There are also different receptors in different cells, and the processing of these signals in the brain is also different. So essentially, is it pain or pleasure? It depends on the fibers that transmit the sensations and the processing of them in the brain. So, if it's nerve fibers transmitting an itch, the sensation will be of an itch. I have patients who complain of itching during sexual intercourse, not pain. I touch their vestibular area. There are patients who experience pain. And I always joke and say that I assume patients who have a multiplicity of pleasure. I don't see them in my clinic probably. They write about it on Facebook or Instagram. They run workshops on how to enjoy things more. There are all sorts of workshops like that online. Or, another thing I want to mention, there's a syndrome that not many people know about. It's called persistent genital rosacea syndrome. That's essentially a condition where there's a constant feeling of sexual arousal. It's a very, very painful syndrome. Otherwise, life is very difficult. We often struggle with medical management as well. We don't always know how to help these patients. Ian Michal, I would like to ask you if you have any questions. I'd also like to ask you a few things about the treatment. Amos Bogner. Yes, thank you, Evneem. So I'll put it this way. When it comes to hesitation and pain management, in many cases I like to look at it from top to bottom. And from bottom to top, what does that mean? There's the part of thoughts and feelings that affect the body. They influence how we experience things. And there's the part of working on the body. As Marcel Ponty, a French philosopher, said, what we do with our body affects our thoughts and feelings. In Jean Montague's approach, the work with the body is to prove to the body again and again that exposure and entry into a sheath are safe. And this is done gradually. And sometimes insertion requires starting to work with the imagination, to imagine something entering. And sometimes it's possible to begin directly. But at some point it happens. It starts with trainers to fit a small case. Practice, practice. And when it becomes easy for her, you move on to the next size. And that's essentially it. We're getting a great deal of help from a pelvic floor physical therapist. She essentially guides and accompanies the practice. And not just that. She also explains other things shortly. So, essentially it's working with the body and together with it. This is sex therapy. It's individual or couple sex therapy. Which is basically that. Dealing with the anxieties and the thoughts. Dealing with their sources. And also practicing with your partner. So basically, the ideal treatment if you have the resources. Combining both things, also physical therapy for muscle exercises. The pelvic floor and gradual entry into the vagina. And also treatment that addresses feelings, thoughts, and the relationship. And I have questions for both of you. Yes, a question that I think both of you have been asked many times. It was meant to be. Thank you so much for writing. It's a topic that isn't discussed very often. Men live under a sense of shame. I want to say something about this in a moment, someone. Is there no pain during penetration but also no pleasure in the area? Is this something that can be treated? I want to talk about something regarding shame and share a little about what I've been through. Leading up to this day, I reached out to a friend who writes for one of the leading television networks. And I told him, we're doing an awareness day for pain in sexual relationships. And that is incredibly, incredibly important. At least 20% of people suffer from this, and it is an unspoken matter. I'm always very optimistic. I'm sure people will say, okay, let's do it. 2 large international companies gave us sponsorship. I want to mention that to all of us. It's a very remarkable thing. Especially at a time when we're getting cold shoulders for these kinds of things. For so many things. International organizations simply because we are Israelis. We have stories from here to the present day. What happened to us at conferences over the last 3 years? And getting sponsorships, that is a very, very significant thing. As Dr. Yuval Lavi mentioned, it was Sharon Pellick-Nesher's initiative. And it's truly an accomplishment. A very big one. No one wants to deal with this issue. So I hope that on the 5th Awareness Day they will feature us. A report on television. I believe in it. Things happen slowly. But I think this issue, a topic that isn't talked about much, men living under a cloud of shame. And many women also live under a cloud of shame. I really hope that as a result of today we can begin to change the conversation. It will probably take us a few years. But when they talk about pain in sexual relationships the way they talk about headaches or back pain, then we can retire? Then we'll be back in touch. Is there a treatment? If there's no pleasure but no pain? Then I'd say that everyone's erotic map is very individual. Different women will enjoy different types of contact in the vagina and clitoris. And at what angle? And with what intensity? But the issue here is women who do not enjoy penetration. Let's call it what it is. It's not that. It's not rare. It's quite common. There are women who would say I enjoy the connection. I enjoy seeing him enjoy it. But the device itself doesn't give me pleasure. I'll say it's possible. It's possible to learn. It's possible to try to understand why it is. Is it something anatomical, technical? The sheath is the most sensitive area. It's also the area with the greatest potential for pleasure. It's on the front wall of the sheath, close to the entrance. What's called the G-spot. Regarding Ernest Grafenberg, he is the one who discovered it in 1950. There's an area there that we now know is the inner part of the clitoris. And it's not sensitive to touch or friction, only to pressure. Therefore, it's difficult to decipher in order to discover it and derive pleasure from it. Sometimes you need to try pressing different angles and various things. So sometimes it's a matter of simply knowing how to explore, to understand trial and error. And different women will feel differently. But I think that if it's something that concerns you and causes discomfort or curiosity, it's worth to explore it, and to understand and comprehend it deeply and see what can be done about it. Definitely. Yes, there is. Here are a few more questions. Dr. Anat Alran wrote that in women with vaginismus, there's a correlation to difficulty during a dentist or dental hygienist examination. They also experience difficulty with blood tests. Furthermore, they have difficulty with injections and vaccinations. We definitely recognize this. I often ask them if they have any difficulties swallowing pills or inserting contact lenses. And there's often a correlation. Michael, is there anything else you want to say about this? There are just a few more questions here, so let's move on to those who are asking. You or someone isn't seeing improvement with the trainers and emotional therapy. There's still pain. I have an answer for that too. But yes, you respond. So my answer is, I told you again. I never ask what the treatment is, and emotional therapy is treatment. I always ask what the diagnosis is. I also teach doctors who study with me to ask. We need to always ask ourselves as therapists if we missed something in the diagnosis. And that means I will re-examine the woman. And I will see if I missed anything. I will do some kind of assessment, a broader assessment. Maybe it's not just an emotional issue. Maybe it's not just a physical one. I'll give an example. Cases I see every day, women I treat, I've noticed excessive tension in the pelvic floor muscles. I referred them to a physical therapist. The woman came back to me and told me there was an improvement. And then the pain returned. And I always try to figure out what the trigger is for the return of the excessive tension. And I gave you a list of many things that cause excessive tension in the lecture. And I'm just going through things with the woman one by one to see if it's some physical component. It could be a posture problem. For that, I'm referring her to a physical therapist to do a reassessment, to see if it's an emotional issue. Then I'll refer her for emotional treatment. Could it be a different problem? I think we should always first ask ourselves if the correct diagnosis was given. That's the first thing. The second thing is that many times I say, if I haven't been able to help a woman, I release her. And I recommend she go get a second opinion. I believe none of us, truthfully, has all the answers. And if I can't help a woman, I'm the one who suggests she seek a second opinion. So different therapists have different treatments, different approaches. I do believe it's important to move forward. What is your opinion? Michal? Yes, I agree with what you said. I have nothing to add. That's good. That's how it is in a good relationship. Do you agree? Someone wrote, I would appreciate it if you would talk about the pain that can occur after sexual intercourse, and not just during penetration itself. For me it is mostly a very intense burning sensation. Several hours later, I'll put it this way, I presented a slide. And I said that pain during sexual intercourse is a very, very nonspecific issue. From my experience, many times pain during sexual intercourse that lasts for several hours afterward is actually a reaction of the muscles. The muscles go through some kind of phase during sexual activity. And the sensation of the muscles is often a feeling of burning and stinging. I often press on the muscles, and women tell me, but it gives me a burning sensation. Feels like a wound. It doesn't feel like a healthy muscle, right? Often pelvic floor muscles feel like a burn, so that's one possibility. Another possibility is congestion of blood vessels. There are women who suffer from a medical condition. The issue is essentially a disputed case of blood vessel congestion. Part of the expression of this can be a burning and stinging sensation, and a feeling of heaviness after sexual intercourse. Another reason is reactions to seminal fluid. We recognize a relatively rare condition of a true allergy to seminal fluid, including a reaction, anaphylactic response. I had a patient who came to the emergency room once. She required resuscitation after sexual intercourse. Very frightening. But since then she's been taking antihistamines and she's doing okay. But we know many women who experience burning as a result of the semen itself. So there's a relatively broad differential diagnosis here. I recommend that women who experience burning after sex start by always using a condom and checking that. If you have sex with a condom and you don't experience burning, then you do. You have a reaction to semen, and then you simply use the condom. Or you take an antihistamine or there is an allergy. I always refer patients to the immunology clinic at Hadassah Ein Kerem. They deal with all these reactions to semen. If this burning sensation occurs despite no exposure to semen, then the possibility of muscle spasm should be considered, and an appropriate evaluation should be performed. I have a question for you. Is it possible to fully recover from an overextension, or do you need to learn to live with it? The answer is a definite yes. And many women have reached out because it's one of the things they've experienced and also initiated. That feeling, it won't happen to me. I'm not like, it's one of those catastrophic thoughts. I won't ever be able to get out of it, and that's not right. Because we know and support women. Every few years they send pictures of another child being born. You remember when there was a problem. And it's like something that you can definitely leave behind. Behind? Yes, don't lose hope and reach out to professionals. And the answer is yes. And yes, I want to ask something. Ohad. Are you there? Do you hear him, the fan? Because I can't see the picture. I think the picture is a little. Maybe there's a problem with the internet, right? It's the fans, I think, because I'm a fan too. Oh, here we go. Okay, it's back. Sorry, not for long. Yes, there was a problem with the internet. I think like we're the most known. We've been in this field for many years. And you can see that awareness is growing slowly but surely. Of course, there's still a long way to go. But we are in a completely different place than we were 20 years ago. But regarding men, there's no awareness even among urologists. The fact that it's a double issue and also not in the general population. As if there's a man, we have patience. Sometimes it's a question from the field. In his penis during sexual intercourse, he consults a urologist with. And they tell him it's nothing, it's not a problem. So the specific question is, someone says I have pain in my penis when entering the vagina. Specifically, do you have any thoughts? And do you have any idea what can be done to change the situation? Yes, so first of all, there are more and more urologists these days. Regarding sexual function and pain. So there are more and more urologists specializing in that area. And therefore, there's also increased awareness among general urologists to refer patients. But there are also many referrals from general urologists, so it's necessary to say, referrals have increased not only among the general public. It has also increased among doctors, cardiologists, urologists. But for those who don't know, there is a urologist. And there are also andrologists who specialize specifically in these areas. Now, pain in the penis is. That's something we don't always find. Very clear cases like Peyronie's disease, for example. That's one of the common causes of pain during an erection. It happens generally and especially during sexual relations. But there are other reasons as well. I've encountered reasons that are also uncommon and rare. For example, we discussed a burning and scorching sensation. Often it's neuropathic pain, pain that originates from pressure on a nerve, specifically the pudendal nerve. It affects sensation in the penis. So, pressure on it or stretching it can cause pain. And it's not uncommon in men with chronic pelvic pain resulting from a tight pelvic floor. So there is gout of pain mainly at the tip of the penis, which leaves what used to be called chronic prostatitis, some of the symptoms of chronic prostatitis. Try today CRPS, chronic pelvic syndrome. It's also pain and a sensation of. Pain in the penis and particularly at the tip. For men who experience pain following an infection that has healed. Herpes. And even without sores, I had one patient who had it without having sores. And there were pains that subsided after I prescribed treatment for him. So there are all kinds of pains, even rare ones, that really require you to think and delve deeply and try to understand what the problem is. It's not always easy. Even we sometimes fail in like what she said, it's not always the whole truth with us. If it's necessary to refer you, then we also refer people to the pain clinic sometimes. And we don't try to handle the pain ourselves. You have to say that people with pain is very emotional and psychological. Recently, a man with chronic testicular pain attempted self-harm. The harm stemmed from the pain. Dealing with this has very serious effects on each other. I think there's increasing awareness today and more tools for treatment. But we need to say that we aren't able to help everyone eliminate the pain. And we need to eliminate the pain. We need to help him cope with the pain. Okay, so thank you very much to everyone. We need to finish and move on to the next session.